Welcome back to TEDMED, and our sincere apologies for the technical difficulties. I'd like to go back to our introductions and welcome Janine, who will now introduce herself.
Good afternoon. I'm Janine Boita from United Health Group. I lead a research and development group that's focusing on developing new service models, sort of in a phase 1, phase 2 approach, identifying leading innovative solutions in the marketplace, be they at academics, in the government, or with private industry, and see how we can leverage our assets to bring these services to many folks in the U.S., particularly those who are living with chronic disease.
Thank you very much. Dilip, can you please introduce yourself? Dilip, are you there?
He seems to have vanished.
Now,
Okay. In the meantime, Michael, why don't we have you introduce yourself?
I'm Mike Rosen. I'm the Chief Wellness Officer at the Cleveland Clinic and Chair of the Wellness Institute. The goal of the Wellness Institute was to make preventive and, if you will, lifestyle medicine a driving force for our populations. With the first population we were working with is our 43,000 employees and their dependents. The goal was, in fact, to be able to, if you will, bend the cost curve down by helping them get healthier in 4 areas: tobacco, physical activity, food choices and portion size, and managing stress. And through that, if we could do that, be able to demonstrate we could bend the cost curve down and then export those processes. And we found out there were 4 key processes. Export those processes to companies to help make them be able to be more competitive for jobs and to make the United States be more competitive for jobs.
Thank you very much, Michael. Let's jump right in. We have a lot of questions, and there's a lot of interest in today's topic. So let me get right to it. Today we're going to be talking about chronic disease is America's leading cause of premature death and disability. Heart disease, cancer, respiratory illness, and diabetes are among the most costly and common health problems. Yet they are often among the most easily preventable and controlled. So let me get to some of the questions, and I'll be directing them to each of you, but please jump in, and if you have other comments you want to make. Healthcare hasn't responded adequately to this. What is the single biggest reason? Is it lack of care coordination, emphasis on profits over prevention, or are patients unwilling or unable to implement healthy behaviors? Amy, can I start with you on that question?
Okay, yes. I'm sorry, I missed the very beginning of the question, though.
I'm sorry.
Healthcare hasn't delivered on...
Hasn't responded adequately to chronic disease and illness in America. What is the single biggest reason? Is it lack of care coordination, emphasis on profit over prevention, or are patients unwilling or unable to implement healthy behaviors?
I would say there is, it's absolutely a mix of things, for sure. And I earlier was talking a little bit about the lack of coordination and what a problem that is for patients who are proactive even and who do want to get the best care, and what a fight it is to actually work with a quote-unquote healthcare team, because our system is not set up to support a team, doesn't incentivize or reimburse providers to act as a team, and even actually of late starts charging patients fees for things like sharing lab results with different providers, which is absolutely ridiculous. So you're paying for your own information to be passed on to you or to someone else who's supposedly on your team. So that's obviously huge. I also think that, clearly in this country we have a culture that has not supported healthy behaviors, and that we're starting to hopefully make changes in the right directions, that people are recognizing what a real problem that is, and that even at the policy level and at the school lunch level, everywhere, we need to make that something that's more mainstream to make better choices on food and activity. But I also think what you mentioned about, the reimbursement structure, the emphasis on profits. Clearly, our system is set up that the clinics and the clinicians are paid more at this point for acute problems. For the classic thing with diabetes is they won't pay for a few hours of diabetes education, but they'll pay to have your leg amputated down the line. So clearly the financial structure is wrong. So many things that need to be changed. And I really think that the reason that it's such a quagmire is that it is this complex web of problems.
Okay, thank you, Amy.
Can I just jump in if that's okay?
Sure.
Okay.
Go ahead, Michael.
I think it is that we in medicine have failed to educate the public on how much control they have. So many in the public think that if their mom had diabetes, they're going to have diabetes, or if their father died of cancer, they're going to die of it, and there's nothing they can do. So I think part of the problem is that we have failed to educate well enough in lifestyle medicine, that is how much control physical activity, food choices and portion size, avoiding tobacco, and managing stress, how great those areas are. And even as, if you will, one of our providers said, Bruce Roberts earlier, how great even the mismatch of or not taking drugs, how important it is to comply or adhere, how important those things are to their health care and their health care costs.
Thank you. Janine, did you have anything you wanted to add to that?
Yeah, I couldn't sort of agree more in that, there's just, it starts in my mind with a fundamental awareness issue, and that awareness issue isn't just among clinicians. We were certainly at the table, but I would say as mothers, as wives, as physicians, as pharmacists, all of us on this call and all of us listening, I think we were caught off guard. So when I look back, my kids now are teenagers, and when I think about when I was a busy resident and fellow and what I fed my kids during those busy times, because throughout medical school, and I am a pediatrician by training, the word obesity never came up, ever. And now we know, certainly it's the greatest healthy eating and activity is the greatest preventive measure of all. But we still have to sort of, A, educate ourselves, but B, educate the public in this whole idea of health risk. And what does it mean to be at high risk? And what is the influence of what we eat and how active we are and how we manage our stress on our day-to-day, and how that absolutely translates into chronic disease. So, I mean, I think, the best thing we're doing is, A, we're having this national conversation. We certainly are seeing an increase in awareness and interest from employers and the government and all of us as just humans in managing this process. But this is a big problem, and it's going to take us all. And I'll end by saying, and if we think that we will handle this purely in the healthcare system, we will fail. So, for example, it's not that the drugs don't work for diabetes often. It's that for some reason, people aren't taking them. And sometimes it's side effects, and sometimes it's cost. But I actually think it's deeper. And so, we need to start learning from the media industry. We need, the healthcare entertainment. Why is it that some of these just awful shows on TV have millions of people watching them every day? It's because they're entertaining. And we need to sort of take some of those learnings and go for it. And say, how can we make it less clinical and more about healthier living every day?
Thank you very much. Dilip, let me ask you the next question. What are the top contributing factors for the great challenge managing chronic diseases? What do you think are some of the top contributing factors to managing chronic diseases?
Thank you, Rosemary. I'm sorry I sort of pushed off there for a bit, another technological snafu. Basically, again, I'd like to take the discussion back. I mean, the discussion heretofore has still been very clinical in the sense it's focused on a classic, even albeit an emancipated medical model with a focus on prevention, with a focus on behavior change. But The biggest reason we have the current chronic disease epidemic in this country is you have to go back to the classic socio-ecological model. Let me again begin with what we did in California in the late 80s and the early 90s. All we did is we paused, the two big risk factors for most chronic diseases are, and you all know this, tobacco and obesity. Obesity, which is diet, physical inactivity. And what basically caused this over the last 4, 5, 6, 7, 8 decades? Well, exactly what we did in tobacco. We paused the behavior of tobacco use all the way from the growing of tobacco through its manufacture, through its predatory marketing, through retail sales, and looked to see how we could intervene with this societal atrocity everywhere it occurred outside the medical care system. And I think that is pretty much when we did this in California 20 years ago, it was looked on as one of those weird California things. Well, I think the same thing needs to be done with diet and cancer, diabetes, cardiovascular disease. You've got to look at the societal cues. And people talk about incentives and disincentives. Frankly, the cause is relatively simple. You have an indolent society, and it's societally fostered indolence. It is a society that eats the wrong things, and there's predatory marketing in extremis by the food industry. I think just Google the Rudd Center or Google any major think tank, and to focus on the diseases itself. When I trained in medicine in 1968, I got my degree. You had type 1 and type 2 diabetes. When I left California 7, 8 years ago, I could cry. I had Hispanic children in high school getting type 2 complications of type 2 diabetes. So we have to have an in-your-face intervention outside of the medical care system.
Thank you, Dilip. That's great. Do you want to wrap that up?
Me?
Anyone else like to comment on what Dilip is saying or add anything to that?
Well, I think that the issue is it's a very broad issue. I think Janine really nailed it. I mean, this is in healthcare. I think one of the challenges that we tend to talk to ourselves, and we really need. This is a much broader issue. I think Dilip brings up some important issues as to how we address this just looming crisis. That we've got to have a national debate. We've got to find ways to better integrate the healthcare team. We've got to figure out ways to better coordinate care and make sure medicines are used correctly, and really address a lot of these socioeconomic issues that are really causing the crisis that we find ourselves facing today.
And to Amy's point, the bottom line is the doctor's in the mirror.
Yeah.
Thank you very much. We have a question from Twitter right now from Leslie Kersian, who asks, what do I do with patients who are resistant to any kind of help with their chronic illnesses and any behavior change related to that? Michael, do you have any thoughts on that?
I missed part of the question, but it is what do we do with behavior relating to the chronic
Well,
disease?
how do we convince patients who are resisting to treating his or her chronic diseases?
Well, the only ways are either educating them about what is important or incentivizing them strongly. So
I had something to say about that.
we give aha moments where we try and show them with a similar patient how much control they have, how much better they can make their life. The second thing is to get them or their cohorts to change their environment. If you have Chips Ahoy at home, you will eat the Chips Ahoy. That bag will prove lonesome. The third thing is to provide programs and coaching, and the fourth is large incentives when they change. So in the model we have, if they get a 5 normals, normal blood pressure, weight, hemoglobin A1C, LDL cholesterol, and no cotinine in the urine, plus their immunizations, and they get those 5 normals, they get a rebate of $2,000, up to $2,000, which is their entire, if you will, their own personal part of their healthcare premium. And $2,000 is big enough to motivate most people in our system. Over 63% with chronic disease have in fact transformed, and 94% of the people with normals have kept normal. So in fact, there is a way of doing it and motivating most people and not having resistance.
Can I jump in there? This is Amy.
Great. Yes, please.
This makes me crazy because I feel like every healthcare discussion and conference that I go to, I always talk about patients like they're these sort of other beings. I mean, I'm a patient, that's why I'm here. And I think you cannot overemphasize the importance of sort of coaching that's lifestyle coaching and peer support. Because, you know, it's one thing, we all know what we're supposed to do. Like, here's your instructions, go home, eat better, exercise more, take this medication this million times a day. Here's your math to figure out the dosing, by the way, which is extremely complicated if you're on insulin. You know, for people who work in healthcare industry, you do it as a job and then you shut the door and you go home at night and you're done. That's not how it works when you live with a chronic illness. It's every day, every minute, all the time. And it's really, really hard to stay motivated and to keep caring and keep paying for it and keep doing everything you're supposed to do. And I think there's so little recognition of that and so little actual support for people's real lives with these illnesses. So I think that, you know, even diabetes education these days is still a little bit like the finger waving of this is what you're supposed to do and this is how you're supposed to do it, as opposed to a kind of a coaching model that's helping understand the person's environment. I mean, if you're a chef in a restaurant, which we actually had a patient like that who was failing at his diabetes meal plan. It turns out the guy's a chef in a restaurant in New York and he's around food all day and he has to taste it. But nobody bothered to ask him, what does he do all day? So super important, and I think, you know, people are discovering more and more that reaching out and finding other people, other human beings out there who are living with the same illness and who have dealt with some of these things in their real lives is extremely motivating. It's, you know, it just helps people psychologically not feel like they're freaks and they're alone, not feel so isolated, and to just kind of get some understanding of how to deal with the day-to-day. And that's why these social media connections are so important, and that's why these new programs are so important that are coaching and mentoring. And there's one, for example, being launched for prediabetes by a company called Omada Health, where they actually find these sort of seasoned peer, you know, supporters who actually form a team, and then they use the web to connect in a similar way that we are now with each other and keep each other motivated on different markers, A1C, weight loss, you know, changing food habits, changing exercise habits, etc. And I think going forward, that's going to be more and more important.
Yeah, and I think from the pharmacy standpoint, it really is the focus of RxAlly, and what we're doing is the pharmacist is the most accessible to healthcare professionals. They see the patient from 12 to 14 times a year on average, and the focus is to really to have the pharmacist integrated into the care coordination and be working with these patients to support what the diabetes educator and the physician and the rest of the healthcare team are saying to these patients, and making sure that they're doing everything they can to be a supportive member of the healthcare team.
I got to be honest with you, I know very few people where the pharmacist actually plays a role in their day-to-day care. I mean, if you live in a really small town and you really know the pharmacist, maybe, but if you live in a suburban area where you go in, it's like being at the DMV. That's what a lot of our patients say. You know, you go in and the pharmacists don't know who you are, and they don't even understand the medication sometimes. It's just a problem. I mean.
Well, and that's the focus of ours, is to change that, because we've got a very educated the medication experts, and ultimately have a lot to contribute. And in many communities that is the case. But I hear you loud and clear, Amy. It's sad to see where how pharmacy has evolved to just be truly seen as the purveyor of the commodity, and not playing that integral role. And that's the focus of RxAlly, and what we're all about, is to to really evolve that model and change it.
Yeah, and I mean, you do have to recognize that a lot of people with chronic illness use mail order for their medications because that's actually something that helps you, that makes your life easier. That you do not, because I'm, for example, on 7 different medications, and if I went monthly to the pharmacy, I'd be at the pharmacy every day because they're not coordinated, the dates. So being able to get stuff via mail order is extremely helpful. Of course, you have to still use it properly, right, when you get it. So
and that's right.
Outside of the point of purchase.
Yeah, and a very good point. And then the focus is a couple things. One is to have 90 days available at retail, but also, I mean, some of the programs that we're working on at RxAlly are a medication, a MedSync program that brings medications so that all medications are filled at the same time each month or each 90 days. Where the pharmacist then meets with the patient to make sure that they understand the importance of being compliant on their medications. The real value of the face-to-face relationship as opposed to the mail or a phone call, if that, is significant. And the focus is to change the model. I'm not going to make excuses for what the model is today, but it ultimately needs to change because the pharmacist can bring an awful lot of value.
Thank you, Bruce. I appreciate that. Let me take another question from Twitter. We're getting a number of questions in today. And Dilip, let me give this to you. Here's a question also from Leslie that says, so much chronic disease occurs in geriatric patients. Why aren't there more resources targeted, especially towards the elderly or those with dementia?
Again, I hope you didn't ask the elderly question, because I am the old one in the group, Rosemary, which I imagine I am. But let me I'm nearly 70, so I think I trump just about everybody else on this panel.
I'm not sure you do.
Okay. Let me turn around and answer it this way. Most healthcare costs, and again, I would like to move the discussion further upstream than where it has been. What are we doing with patients? What are we doing with the elderly? When I think of managing chronic diseases, Rosemary, I think not just of managing. I think you have a superb panel to see how you can manage patients. I think the focus needs to be on reducing the incidence of chronic disease. I think the focus needs to be in keeping the well, especially for elderly populations. 50% of our health costs are related to people in their last year of life. So I think both from financial as well as from a lifestyle point of view, especially for the elderly, you need to focus on how do you keep them healthy. And there are a whole bunch of areas. Elderly is one group. Remember I talked about clinical management and clinical prevention, which are the areas many of the panelists are focusing on. I prefer going a little further upstream to behavior change, laws, regulations, and policy. Let me give you a couple of examples. Behavior change, some of the things that Michael mentioned that they're doing in his clinic, it's so great. You have incentives for an individual. But what I would like to see is keep the well elderly well at home before they show up in Michael's clinic. You have exercise. Stanford has a great model for the prevention of chronic disease. We use it here in Hawaii. You go to senior centers, you make sure they have exercise programs, you do systemic interventions, you make sure that the dietary intervention there is not as heavily loaded in fats as historically it's been. You limit soda, fast food availability in these centers. You regulate vending machine content. And then, to the extent you can, have daily physical education programs. You'd be surprised how many people who in their 80s, even their 90s, in our local elder programs, we have them involved in doing exercise up to their ability. And sometimes the older ones compete in our...
So you do think that there are programs that are addressing the elderly?
There are, but rather than think of programs, the elderly also have a function in making sure that society will change. The societal cues, we've focused heavily on that. Things like McDonald's, things like Burger King. People don't like to demonize the food industry the way we did the tobacco industry. You don't have
Anyone
to
else on the panel have
Yeah,
a
this is
comment on
Denise.
what Philippe is saying?
Yeah, thank you. You know, I'd sort of boil it down. I'm going to just start by focusing on women over 65, women. And it's interesting is that, you know, at the end of the day, if you look at their top priorities, exercise and healthy eating actually are not on the list. And, you know, I think it goes back to that a generation of where it wasn't a focus of what we did every day. But here's the good news. What do they care about? Their finances. Number one, they're very concerned about their finances. Number two, friends and family. And lastly, staying in their home. And if we can use those learnings to say, okay, if we sort of message to people about at a societal level that, hey, if you want to live longer, not have to spend all your money on medications, but have more time with your friends and family and stay in your home, get out every day and walk and small lifestyle changes, not a dramatic diet, but just, you know, much in the way the diabetes prevention program does small lifestyle changes. I think this group will be the most amenable because those three driving factors are just terrifically important to them.
Okay.
To the last point, Rosemary, we had a program in California I loved for the elderly. We called it the Excuser Size Program. Not exercise, the Excuser Size Program. And that focuses exactly on what was said by, I believe it was Denise.
Okay, thank you. That's great. Another question, Dr. Rosen. Let me direct this question to you. This is a Twitter question from Sue Wentz. I'm interested in how cultural, spiritual, and religious issues are integrated into care of managing chronic disease. Persons' beliefs and values impact not only how they understand their illness, but also how they participate in medical and complementary treatments and cope with emotional and spiritual distress. Do you have any comments on that?
Yeah, I'm not sure how to make it other than it's an individual thing and it's individually and done universally with each person, but it relates to really managing stress. That is, how do you help each person, because each person's, what stresses you may not stress me and vice versa. So I think it is learning how that affects people differently and learning how to approach it culturally in a culturally sensitive way is important. I'm probably not the right one to answer this question. I do want to get back to Dilip's statement. They don't come to the clinic. We change the clinic environment for all 43,000 people. So yes, there is a aha moment where everyone gets to see why this is important for America, why it's important for them. Yes, there are environmental changes, so they can't buy a soda. So we actually have food prices that are different to favor healthy foods. They can't smoke on campus, and that's rigorously enforced. And yes, there are free fitness facilities, and yes, there's free stress management programs, and yes, there are large incentives to help people keep motivated when their buddies and yes, there are social programs and coaching programs that we offer, but those are, if you will, individualized to the person. That is, we have developed an automated system that can be individualized culturally to the individual, and then deliver it in a very inexpensive way to large groups of people. So that has to be done, and I apologize that was more on the previous question than this one.
That's fine. Does anyone else have a comment about that question? About the spiritual and emotional
I think that's, well, more cultural, I would say. I mean, definitely there's been some really great programs to reach out to the Hispanic community around diabetes. I know Jocelyn Diabetes Center has done special books and programs and even like a telenovela. I think those things are extremely important when it comes to diet in particular, and also the stigma associated with disease. So in the Latino community, apparently, you know, diabetes is something you don't share. You call it a little bit of sugar, you keep it hidden, and it's, you know, it's not something that you're sort of out there with. So they're really trying to help change that people aren't ashamed to talk about it, that they understand the seriousness of it. And also, you know, different cultures have diets that are very heavy in carbohydrate and fat, and so helping people to still cook their traditional foods, but to use some alternative ingredients and be aware that how important that is, again. So I think it's, you know, there's a lot been done in the Hispanic community. There are definitely other minorities within our own country, and obviously non-minorities in other countries, where we need to sort of adapt those messages to help them, because their culture is going to, you know, have a big influence on the way that they, you know, the behavior change that they're willing or able to implement.
Okay. Thank you. I think a lot of the discussion has focused on nutrition. And one of the questions that's come up here is that so much of chronic disease is related to nutrition. How has that factored into the medical model, and how much are physicians in their dialogue with patients actually now talking about nutrition and making that a priority in talking to their patients? Does anyone want to talk about that?
I think certainly in pediatrics, you know, I think for lots of different reasons, pediatricians often are first to the table, no pun intended, of taking on new learnings and frankly, I think adults often, when you think about adult behavior change, because that's what this is, it's a behavior change. Adults will change on behalf of their children before they'll change on behalf of themselves. So women, we know, quit smoking when they're pregnant, and they didn't quit smoking when it was just for themselves. So it's a great opportunity to leverage children and their learnings. And, you know, I really don't think we should beat up on the schools. It's too easy. But, you know, they are changing their menus. Some of the resistance to the problem are actually from the home. But that being said, we got seatbelt adoption in this country when children got in the car and said, "Mommy, put your seatbelt on." And the same thing I think we're going to see with nutrition. It's going to, you know, we are seeing the pediatricians and the parents on behalf of their children begin to change diets and confront the issue of how nutrition affects healthcare. And hopefully that will carry over into the adult space.
Anyone else have a comment? Again, what we're trying to get at, and we just have another Twitter question here, is about, you know, the training that medical doctors have, how it's discussed in the clinical setting. Is nutrition really coming in? There's one doctor here, one gentleman who sent a tweet right now, talked about being in medical school and that most of his training is right now focused on acute medicine and not so much on preventive. And, you know, really getting at the importance of medical education.
The schools are trying to do more, but are not doing as much and as you and I would like them to do. And a major problem, I mean, if you look at cardiologists, when you speak about heart disease, they require no cardiologist is required for board certification to know anything about nutrition. So there's a dreadful lack, and it's partially, if you will, in the certification process. We have not required it at all.
Okay.
But if we're being totally transparent, I think a big question is how much time is in the day, and maybe it's time in the healthcare system. And I realize we've spent a lot of time talking not about, but let's focus on the healthcare system. What do we want physicians to actually do, right? So maybe it is, in the end of the day, primary care should go well beyond physicians. And because there's just not enough time in the day, and those same cardiologists, they have to see all their acute problems and take care of business. And if you're having a heart attack in that ER, you're going to be darn glad that he or she was there to, you know, to help you. But that being said, we must address nutrition. But how do we bring it into the bigger care team? Because maybe it's just not physicians.
Okay.
Again, the focus, Rosemary, on diet again has been, and there is a role for that. There is a role for a clinic, physician, and other healthcare professional focused on diet and physical inactivity. But basically, the more complex you make it to educate cardiologists, as Michael has said, and do a whole slew of other things, you're going to have an increase in medical care costs. I think if you do the upstream strategies, if you go, at some point, we have to see that the control for the obesity epidemic lies arguably 20% within the healthcare system and 80% elsewhere in society. If you look at what CDC is doing in terms of obesity control, their whole focus, $750 billion worth of a focus, is on policy, systems, and environmental change. And what happens? The lower house of Congress and the House of Representatives, they said it's inappropriate to look at policies relating to food, to look at policies where you quote unquote demonize anybody. Well, the fact of the matter is this did not come on because we're a slothful society. Once we have cars, once we don't have built environments, people don't see place matters. There's a gorgeous study that just looks at the subway map in Washington, D.C. It's a case study on place matters. If you look at the different parts of the red line, the yellow line, and others, there are mortality, morbidity differences up to 25% just based on where you live in D.C. Same thing in Los Angeles. So you have to affect that external environment, the societal cues. It's difficult to do. But to keep focusing, saying the healthcare system is going to fix it, hallelujah.
Yeah. This is Amy. I would love to weigh in there. So I think what you're saying, is that, you know, we have this system, our quote-unquote healthcare system, which is actually, as people say, a sick care system, right? It was set up to treat people when they have some kind of an illness or an injury or, you know, a medical issue. And now we're suddenly saying, but now they're responsible for, you know, prevention of that people should, you know, behave healthier in the first place so they don't have to go to the sick system. So that system isn't set up to support that. It's not paid for that. It's not, you know, it doesn't have the personnel. So I think that's, you know, what we really need to do is add a whole other arm to this system, or even a separate system of health education and coaching. If, you know, and again, and it definitely has to be integrated at the societal level of encouraging people to walk rather than take the elevator, and to, you know, not eat fast food 5 times a week, etc. But I mean, it has to be something separate and in addition to the system we have now.
Thank you, Amy. I just want to mention that we are going a little over given our technical difficulties, so we'll take 1 or 2 more questions before we wrap up the discussion this afternoon. Okay, just to move on, we have another Twitter question that came in from Toppleresque, and it says, how to win patient adherence in Medicare and TRICARE populations? What do we need to do to win adherence and to chronic disease adherence? Does anybody want to take a crack at that question?
Oh, I'm so sorry. I had a little technical issue, and can you repeat the question?
Okay, sure. This is a tweet from someone who asked, how do we win patient adherence in Medicaid, and TRICARE populations?
Okay.
Amy, would you like
Well, I don't know if I could talk specifically to that population, but I mean, the whole adherence issue is big, also big and wide. It makes me also a little frustrated to, you know, this whole idea of compliant, non-compliant, adherent, non-adherent, as if we're all a bunch of naughty children. You know, again, people know, for the most part, they understand, like, oh, I have this, you know, health condition. They're either accepting of it or they're rejecting of it, you know, depending on a lot of different factors. I mean, a lot of it has to do with how happy they are in their lives, what else is going on, what resources they have, you know. And I mean, you know, so adherence issues go from everything from just truly not understanding, you know, what the requirements are of a certain medication, to not being able to pay for it. I mean, we've had, you know, people who don't refill their prescriptions because they have to choose to buy groceries for their family instead. Or, you know, issues of, you know, there are a lot of factors that go into it. But I keep going back to the idea that people need coaching and assistance that it's not just about remembering to take a certain pill at a certain time, that it's a bigger issue than that, for them to really get motivated and also to feel that efficacy, that they can actually make a difference in their health. Because I think a lot of people, especially older people, you know, they are on these 12 different pills. It's super confusing. You kind of give up, and you also think at some point maybe it doesn't really matter that much. My glucose levels are always high, so you know, why am I killing myself to do this? So I really honestly think people need support outside of the clinical environment, and it has to really plug into what their real lives are like.
Thank you very much, Amy. That's a very, very important answer. Dilip, I have one question for you, and then we'll wrap up. What is the greatest prevention measure we can take for cancer prevention?
Again, I couldn't hear your question, Rosemary. Would you repeat it?
Okay, sure thing. What is the most important step we can take for cancer prevention?
There is not one most important. There is no panacea for cancer prevention. But again, it's still, the vast preponderance of science indicates that a third of cancers relate to diet, a third of cancers relate to tobacco use. So besides doing the societal cues that promote eating the wrong things, exercising less, and using tobacco, I think we need to focus on prevention in the healthcare setting, but in a way in which it's cost effective. Because my only problem with focusing extensively on prevention only in a healthcare setting is you have additional costs without always the sort of yields you want. Let me sort of address that a little broader, if I may. We've lost most of our panelists, Rosemary, but I don't know how many of them have heard of CHNA. Amy, since you're, have you heard of Community Health Needs Assessment? Well, it's very simple. It's required by Obamacare, by the Affordable Care Act. And it says what are the upstream interventions that we can do, and we need to have the healthcare system invest in those upstream interventions.
Okay, thank you very much, Dilip. I want to thank the panelists, and I'm sorry we had to lose some of them because of the time and technical difficulties. But I want to thank all the team members who provided their time and thoughts today, to everyone in the TEDMED community who watched and sent in questions. If we didn't get to your questions today, remember the Great Challenges Dialogue is always in session on Twitter and at TEDMED.com. We'll be taking a hiatus for the holidays, but we will resume our Google Plus Hangouts on Thursday, January 3rd, talking about treating the whole patient. Finally, we want to say thank you again to the Robert Wood Johnson Foundation, who is the sponsor of the Great Challenges program. Thank you very much, and have a good holiday.